I think Eli's going to join in a little bit later when it gets closer for us to present.
Our session. And welcome, everybody. Go ahead, Maria.
Hi everybody. My name's Maria. I'm a patient care navigator with Ancora Home Health and Hospice, and I'm here with Anna. She's our administrator. We're really excited to share what we do in the community, and so we're very thankful that you had us join you today. We made a slideshow. We're going to go through, and then, like you said, after, if anybody has any questions, we're happy to answer those. So with that being said, we'll just go ahead and begin, if that's okay. Is
That's
everybody
great.
ready? Okay, so we are Ancora Home Health and Hospice. We are a home health agency that goes to patients' homes that are looking to reach their healthcare goals. If we get a referral from their provider, um, we typically come into the home or wherever they call their place home. So just give me 1 second here. I'm gonna go to my next slide.
No. There you go.
Okay. So we're going to do a little truth or false. So what we really like to educate on is hospice and the hospice benefit. So we notice that it's a service that doesn't get utilized enough and people kind of wait too long to use it. So we just kind of wanted to put this together because there's so many misconceptions. Hopefully these will answer any questions that anybody may have. So we play a little truth or false game and Anna will help me go through these. So we're ending hospice misconceptions, one question at a time. So our first one is true or false? Hospice is a facility you must be admitted to in order to receive care. So that's one of the things that a lot of people think they need to go into like an actual hospice facility. But that is false.
And
So the
Maria, I know
truth
you can't
is
see the
hospice
chat,
is
but the
provided
folks are in
wherever
the
the
chat,
patient calls home.
and I know you.
So the majority of patients prefer to remain in their own home where they're obviously the most comfortable. But if that's not a possibility, then we look for other options. They can always have hospice care in the facility that they live in. So that is the first one. We're going to go to the next. You want to do this one?
Yeah, true or false? Hospice is only for those who are bedbound with limited to no mobility. This is always a big one too. For us, it's super important that we try to get people on at least 6 months before they pass. So a lot of times they look great. They're walking around, they're talking, they're still going to the store. They can look healthy. They just have to have that diagnosis that qualifies them, but they do not have to be bedbound. They don't have to look like they're actively dying. That is definitely a misconception.
Yep, so that is false. So they can look active. We encourage them to do as much as they can while being comfortable to maximize their quality of life. So our next one is you're only allowed one 90-day benefit period on hospice. So that is definitely not true. We have had people on our hospice service for over a year at times. So as long as they have a terminal diagnosis and they are showing a bit of a decline, they could be on hospice for a longer length of time than just 90 days.
Yeah, we've had them on for like 2 years, 3 years. Sometimes the ones, especially like a dementia diagnosis, they can live a very long time. But with those small incremental levels where they're just decreasing a little bit.
Yeah, so as long as there's a decline, sometimes it can be a very little one, but that is definitely false. So they can be on for longer lengths of time. What we're seeing a lot right now is that they're on for shorter periods of time, and that's why we like to educate any patient advocate, any provider, just so they know that it's a service they can have for longer than 90 days. True or false? Patients who receive hospice services may live longer than those who don't. So we basically just kind of answered that. But I think it is proven that people on hospice tend to live longer.
Yeah, if you get them on at least 6 months in advance, they tend to live 2 months longer. We have found it's really kind of an interesting thing when we bring people on. A lot of times we're taking them off a lot of the medications that they've been on, and they kind of like rebound a little bit. They start to improve, their mental acuity improves, they do better. So it's kind of a crazy thing that happens, but it's definitely true that they live longer.
They get so much extra support with the hospice benefit as well. So they are getting more visits from nurses. They are getting spiritual support. They're getting social support from volunteers and our social workers. So that's why they kind of feel like they stay around with us a little bit longer. And then they're avoiding going to the doctor,
The
no
hospital.
more hospital visits, and they're just kind of enjoying their last couple months
On
or
their
longer.
terms.
Yeah, however they choose. So true or false, family and loved ones do not get to be involved in hospice care planning. So obviously that is completely not true. Let me go to the next one. The patient basically remains in control of their care. We highly encourage their family to be a part of it. We would love for the care coordinators to be involved with their care. When a patient does come on hospice, they are accepting us as, our medical staff as their new kind of like primary care. So we kind of take over everything for them, but that doesn't mean that we can't give them all the resources and make sure that they still have care coordinator support and any other kind of PCA agency that typically the hospice benefit typically doesn't affect any of the things that they already have in place. I know last week I talked to somebody on that qualified for hospice, and their PCA basically said, no, you can't do that because that means that you wouldn't get me to take care of you anymore. And so I had to set them aside and say, that is not true. Nothing would change besides you getting more help. So that's a great thing for you to know. And if anybody has any questions, we can talk more about that after this. We'll go ahead and go to the next one.
Hospice care is covered by insurance, which is definitely true. That's one of the benefits. We've already, they've been paying into it, so Medicare covers it. Medicaid, all out, there's no out of pocket. And on top of it, as soon as they come on, all of their like briefs and chucks and creams and ointments, all the things that they need for daily living, are covered by hospice. The bed, we bring like oxygen, we bring all the medications, we bring like a walker and a wheelchair and a bedside commode, all the things that they're going to need, to make them comfortable at end of life, and all of that is provided, and they do not have to pay for that. So it's actually a help for families that get to stop paying for their incontinence supplies.
Yeah, and a lot of times it's cheaper for them to get put on hospice because they're getting all of their pain medications. All of that adds up, and that's all included in the hospice benefit. So typically it's, very little to no expense, and sometimes they're even kind of better off getting it. Hospice is about giving up hope. So this is a big one. So we like to hospice is about empowering them to have the best end of life experience that they can have. So we want them it offers comfort and dignity. And we just want them to have a great end of life experience. We want to give them all the support. And do you have anything you want to say?
One of our providers said, you only die once, you should do it on your terms.
Yeah.
And we want to make sure that they, are not in pain. There's no pain crisis. There's no, having to go back and forth to hospitals. It's just like you saying, I'm ready. I want to do this my way, and I want to be with my family and be comfortable till the end.
So we kind of pulled some data from the National Hospice and Palliative Care Association. It is really hard to find specific data to Alaska. So we're probably going to do a deeper dive into our numbers and what we're seeing, but these are national average numbers. So the Medicare hospice utilization, national, it's 49.10%, and then Alaska's 30. That number, that
That seems
30%,
high.
it does seem really high to us. But like I said, these were pulled from the National Hospice and Palliative Care Association.
And we all know Alaska is a very independent state. Everybody lives independently. They don't want to do, not be able to live on their own and say they can manage everything. And so the amount of hospice benefits that people choose is very low, very low.
Our top 3 diagnoses that we see in Alaska, I think, is cancer and dementia. And what was the other one that you were thinking?
COPD, we see a lot of COPD.
Oh, yeah.
Definitely, heart failure, that kind of stuff. But what we find is that people wait far too long in that diagnosis process to get this benefit.
Dementia is one of our top ones as well. And so a lot of providers that we help educate don't always know that dementia is actually one of the qualifying hospice criteria diagnosis. With that being said, there are a few things that they have to be declining in, but for the most part, if they've lost a significant amount of weight, if they're having a harder time with their ADLs, if they cannot form a full sentence, and they're diagnosed with dementia, that can typically get them on to our service and let us come in and give the facilities or the families a lot more
I was going to say the thing for you guys to know is a lot of times what happens is at the end of that, when people are, a lot of times the facility they're in might be feeling too overwhelmed, and they're like, we've got to like move them out. They're no longer like, they don't qualify to live here. We can't handle these things. But when you bring them on hospice, then they get that added support, and a lot of times the ALF will keep them and allow them to stay through end of life. So they just need to feel supported. The assisted living facilities, they're just out of their depth most of the time. So they just need to feel the support that we can give them.
Yeah, and when they come on service with us, we're also on call 24/7. So that's really important for the facility to know. If the patient has pain in the middle of the night, they know that they can call us and we can talk to them over the phone and try to triage it. And if that doesn't work, then we obviously go right out to them and see them no matter what time it is. So hospice by gender, 43% of men and 54% of women. So women tend to get on hospice sooner than men do.
They tend to, that's because they tend to go to the doctor more, and they tend to talk more about the things that they're experienced. So they get diagnosed a lot earlier than men who by nature, don't need doctors, don't need help.
Mhm.
They can figure it out on their own. So generally speaking, women are more inclined.
Okay, so by age, the older you are, the higher the percentage, obviously. But this kind of just breaks it down. And like I said, these numbers were pulled from some hospice care associations. And so we can just go ahead and go to the next one. But yeah, 85 and older, 61%. We are seeing more people that are younger than 65 on it. As well, but they a lot of times try the palliative route first, for sure. Um, so I will go to the next one. Hospice by race. You did a really good job.
Yeah, hospice by race, generally speaking, well, think about it a lot of times, people of other races don't have access to healthcare. They don't trust healthcare. They can't afford healthcare, so they haven't been seeking it out. And I think a big one is just really distrust of the healthcare system, and that is a huge one for them. And the first thing we always get asked is, how much does it cost? Because that is a huge, they don't have money. They just need help, but they don't have money. So sadly, we see that that Caucasians tend to come on hospice a lot more than other nationalities, which is unfortunate. So we want everybody to get the help that they need, for sure.
I have a really short video, and I hope there's no issues hearing it, but it's about, I think, 4 or 5 minutes. So I'm going to go ahead and play that, and I'll go ahead and start that now.
We're not hearing anything.
Oh,
How do you share sound?
So what you can do is through the share option, there should be a little checkbox that you can share audio as well. You might have to reshare the
You might have
or-
to go out of it and then go back.
yeah,
in.
exactly.
oh, so you want
Stop
me to?
sharing.
Okay. And then share this video. It's like not giving me advanced sharing options. I hope that works. Can you hear anything?
No, sorry, there's no sound.
No. Okay, well, maybe
We just-
we can skip the video and you can add it to your YouTube channel. I'll share this PowerPoint with you. They basically ask her why she chose hospice, and this patient actually elected herself. So she was terminal, she had a cancer diagnosis, she had no longer been seeking any type of curative treatment. She had some pain, went into the ER, and the provider at the ER basically asked her why she didn't have hospice care. And she said nobody had talked to her about it and that she didn't think that she qualified for it, basically, because she thought that she needed to be kind of imminent to get that kind of care. So she had a wonderful positive attitude. She has passed away. I took this video last year. Her name was Patricia Chandler, and she was very excited to share her story to educate more people on the benefit. So it basically talks about how she kind of self-elected hospice after the doctor had talked to her about it. She reached out to her oncologist and told him she wanted the referral, and she had a really, really good experience.
Loved her nurses, loved the support.
Mhm.
And
Asked
just
for a wheelchair, got it the same day, had a wonderful volunteer.
Yeah.
Her attitude, honestly, was probably why she really suffered from very little pain, I think, towards the end of her life. So I'm going to go ahead. I'm sorry that didn't work. We'll go ahead and skip to the next one. Okay, so with your hospice team, you get a primary care provider, which is our medical director, Dr. Melendez. You get several skilled nursing visits a week. So typically, I would say that we get about 2 in the beginning. And then as things progress with the patient, we end up seeing them more often, sometimes daily. But in the beginning, it's usually about 2 to 3 visits a week, just kind of depending on the need. And then they also get a medical social worker to help with any kind of resources they might need. They get a chaplain for spiritual support. And like I said, that is optional. They don't have to have a chaplain if they don't want to. It's just something that's offered to them. And then they can get a nurse's aide to come, even if they're at a facility. We will send CNAs to come and provide extra support to staff to help with any type of personal cares or bathing. Volunteers, we have a wonderful volunteer program, and it's just people that we put through special training that can come and sit with them if they're lonely, build a rapport with them, and just kind of for friendship and just all around visits in case they're lonely. We also have a bereavement coordinator that will help with families at the end of life. We have a bereavement support group that's very helpful to people that are grieving. And I'm trying to see what that was.
I don't know. And we are the only hospice in Alaska that offers what's called full circle aftercare. And that is something that we pay for, that's free to the hospice family, and they can get help like with being set up with lawyers if they need somebody. Assist all the personal estate matters. Like there's so much that goes into that at the end, and it can be overwhelming. And we pay for a program that can help them and assist them to get all of that cleaned up, taken care of, and settled. So it's a
And
really
like,
cool program.
yeah, like we said, we don't know if any other hospices offer this. This is something that Ancora likes to do for their families after their loved one has passed away. It's a wonderful service. I've had to use it myself, and it was really, really helpful. After a loved one of mine had passed away, when I needed help with Social Security questions and death certificates, estate planning, all that kind of stuff. I love when you talk about Bridge.
We have a Bridge program. So Bridge is also a pro bono program. It's no cost to the patient. Those people who maybe they've been on home health with us, and we see that they don't have a lot of resources and a lot of help. They might be declining. And we just don't want them to fall through the cracks, not have somebody that's checking on them. So we bring them on to our Bridge program, and they basically have a coordinator that will call them or visit them monthly, go check in, see how they're doing, see if they need home health services again, make sure that they're, getting connected with their provider, just do little things that can help them stay connected with their doctors, and if they have questions, things like that. So that again is something that we do. And there's so many people in Alaska that just don't have anyone. Their kids have moved out, they're up here on their own, and we just don't want them to be left by themselves. So
And I just checked the time. I know we might be going a little over, so we can just kind of speed through this home health stuff. So home health is a service that we provide for people that are not hospice appropriate, but that need assistance reaching their healthcare goals. So let's say they've had a recent hospitalization and they're a veteran that needs help managing their medication. Then typically we would get a referral from their provider that could help them with medication management. But we also offer skilled nursing if they have any type of wounds, physical therapy if they are considered homebound and they can't make it to any outpatient appointments. We have occupational therapists, speech therapists, social workers, and CNAs that can help. And all we need is a referral from their primary care provider. Or it doesn't even have to be their PCP. It could be the hospital or any kind of specialist that they go to. So this is what we do when they need.
this will be on your website. So just
Yeah.
move through the
Yeah, sorry. Physical therapy. We talked about these OT, speech next. This is our company. So we are under a healthcare umbrella. It's called Aegis Healthcare. So in that we have Ancora, Atlas, Triton Supply, and pharmacy partners. And so I know we really wanted to kind of go through this slide, but we serve as primary care. So we have Atlas Mobile, which is an entity of Ancora. So it's our sister company. And so we go into all of these facilities that we have listed in this PowerPoint to serve as primary care. So please reach out to us if you have any questions. I will have contact information. We are accepting new patients. In the Anchorage area, definitely reach out first so we can make sure. I know our providers are getting pretty busy in Anchorage, so please let us know. If you have any potential patients, we'd love to share the new patient intake with you. We love Atlas. We do a lot of our work with them all the time. And so
We're in the buildings pretty much weekly. We
Yep.
see the patients once a month. We can see them in between if something acute happens, or if they think they have we'll see hands up. If they think they have a UTI, we have phlebotomists that go in, pick up samples, draw labs, whatever we need, we come to them. So we definitely provide that. Go ahead, Denise, do you have a question?
Hey, yeah, I just wanted to say that my mom passed away about 6 months ago, and I brought you guys in for the support, and everything was amazing, everything that you've said, but I cannot say enough about the aftercare. Hope
Oh, good.
Oliver called me, she sent an email, and if you've ever tried to end certain things for people, like their mail or their, just social media, just stuff like that, it's really not an easy navigation thing, and she had outlined so much information I had not even thought about that I needed to do when my mom passed. And I'm actually still kind of plugging through some of it because it's so much information. It was just a wealth of knowledge. And then because she was 82, she had mandatory distribution, she had an IRA, I was just lost with all of it. So they have a Alliance Wealth free Zoom. I had a 45-minute Zoom with this man in Utah, and he explained things to me, and then he allowed me to decide if I wanted to work with him at all. He's a fiduciary. I had 3 free meetings with him because my husband was out of town. I had to come back. And then finally, that 4th meeting, I'm like, okay, we're signing up. And I've been working with this man ever since. And all this was free and easy for me to just understand. And I was so overwhelmed with so many things. And I just can't say enough about it. I needed to give you my
Well,
plug. It was awesome.
I love
Thank you so much.
that. Thank you.
Thank
That's
you,
so good to
yay.
hear.
Anybody else have any questions?
There were some questions in the chat regarding funding, how hospice is funded, and then also if Medicaid is affected by it.
So it is, Medicare pays for it. And if somebody goes on hospice, Medicaid still pays like their facility day rate. That doesn't change. They still pay for their, whatever they're paying for previously. So they don't lose any of that. I don't know if we can see the chat,
Oh,
so.
maybe click right there.
Yeah, you're right. That was a really good summary. Most of the questions were about some, combinations of funding and resources like that. So we understand that waiver services and PCS services are still paid because it's Medicare
Yes.
that funds it.
Yes.
Yep. And with
Yeah.
like Atlas, like our primary care, we accept, again, we accept Medicaid, Medicare, private insurances, and they do allow us to go in and see them monthly, which is a lot more than any other kind of primary care, when you're in the facilities. So it's just so much more hands-on. We have relationships with the nurses in those facilities. We're able to meet with them regularly and try to be proactive about care, like, hey, are people falling? Do they have any wounds? How can we get, home health in there to get that taken care of? So it's just a really great service.
Hey, Maria, I don't know if I missed it. Did you leave your contact information? Maybe you could put it in the chat. I know
Oh,
we
yeah.
have
Yeah,
PowerPoint with folks.
I'll add it to the chat and
Great.
I can send you the PowerPoint. I know you recorded it, but we can add it and then I will put Anna's contact information and how to get a hold of Atlas.
Be awesome. I think folks might have some questions later on.
Okay, yeah.
Absolutely.
Great. Thank you so much.
Sorry we went over. Thank you for the
No,
time.
you're fine. This is good.
It's
This
so
was a great.
much.
Thanks for coming.
Yes,
Jason,
we love
yeah.
care coordinators. Thank you for all you do.
You guys
Absolutely.
can stick around for the other part if you want.
Okay.
Listen
Yeah.
in.
Stay if you
Thank you.
like. Thank you. Okay. Well, that was wonderful. I really enjoyed that information. Now I would like to welcome our nursing facility level of care assessment team, Kimberlina Lopez, David Chadwick, Eli Haroon, and Michaela Schaefer. Go ahead and take it away. Thank you.
Good afternoon, everyone. I'm going to share my screen here. And what I'll share first is from our application checklist. Can everyone see my screen? Is that coming in?
That's it.
Yes.
Okay, perfect. So I'll just zero in on what the hot topics are, medical information. Something that we want to see submitted with applications are medical records that are really relevant to what's currently happening with the recipient. We do recommend submitting in chronological order. It does help us when we're reviewing, but if not, that's okay too. In the checklist itself, it does call out the 3 most recent visits to clinics or emergency rooms. That information is really helpful for the assessment. Medical records that are related to long-term care need, records of residential stays, records of therapies, records of psychiatric or mental health counseling or treatments, special treatments such as IV medications, and then outpatient treatments such as chemotherapy. Now, when we have an assessment conducted, we're looking for these items as part of our when we're preparing. So as part of our preparation for the assessment. And then when we're in the assessment, we may be notified of a condition or something that has changed where we might need additional medical records. So if any of these items are not available with the application, or if there have been changes from the time of the application to the assessment date, then we will ask for additional records at the time of the assessment. And the most common items that we ask for at the time of the assessment could be a current medication list, records of surgeries, hospitalizations, ER visits within the last 12 months. And just a tip for those hospitalizations, the admission note, so the first note and the discharge summary are the most helpful with those. The progress notes are helpful as well, but for the most helpful information, the first admission note and the discharge summary are the most helpful. Records of therapies from the 7 days leading up to the assessment or discharge summary if they've been discharged from therapy, and that would be physical, speech, language, occupational, or respiratory therapies. We also request records documenting an individual's cognition, records documenting skilled nursing needs, records of psychiatric or mental health counseling or treatments, special treatments such as home health or pain management records if that's occurring, and then outpatient treatments, dialysis records are something that we often request at the time of the assessment. And some of the things that we've noticed with medical records in our applications, often we see limited medical records submitted with an application, or the medical records do not reflect the current status of the consumer or the needs of the individual. Example would be where we receive over thousands of pages of medical records, but it's all referencing information that may have happened earlier in the year and nothing speaking to what's happening currently, like the 3 most recent visits that they may have had. Another issue may be that there are no records to support a diagnosis or condition that is discussed inside the assessment, or to support an individual's limitations. So documentation to support why an individual cannot do something. All right, I will switch over to our application. This is the first page of the NFLOC 04 application for ALI, APDD, and CCMC. I'm going to scroll through to just kind of highlight the main areas that would be really relevant for the assessment. Looking at demographic information about their communication is really helpful when we're setting up assessment appointments. If they have a different language other than English, it's really important to indicate that there, especially if an interpreter is needed. Sometimes we've had applications come in where they've only listed English as the language, and we go into the assessment finding that there's actually another language spoken or another reason why they're not able to communicate for themselves, such as they're nonverbal, etc. So putting that information here in 8, 9, and 10 are really helpful for assessment scheduling, along with number 11, which is who should we contact for scheduling an assessment. If it's not the consumer themselves or a legal representative, who should we be talking to in order to set up that assessment appointment? So that's really important for us. And scrolling down, I apologize for the scrolling here. We'll jump to question 17, and I'll hand that off to David.
Yeah, so question 17 is really related to emergency room visits and any hospitalizations. So the information that we're looking for in that case is typically we want them, we want over the last year, we would like to know, what's making them go to the ER. Is it something that we have identified as a diagnosis that is causing them to be a repeat consumer there? Is there something that the assessor should be identifying and then really focusing on during the assessment? And so any of that additional information about those visits is super helpful, especially if, we've had something that's happened just recently. We also know that if they've been to the ER, that we may not have the medical records today, but there's something there that we can go and get, right? And something that might speak to a chronic problem or a decline, things that give us a pathway to additional services to help them. So that's really the important aspect here that we're looking for with it, with this information.
Thank you, David. I'll scroll down to 18 and we'll hand that off to Michaela. Actually, 18 and 19 we'll hand off to her.
Excellent. Good afternoon, everybody. So highlighting point 18, therapies. So when the application is submitted and providers are collecting the information from their consumers, we are looking at specifically, is there any active ongoing therapy or skilled nursing care taking place at the time of the assessment? If not, we ask that you not list it if it was months or weeks past, just to kind of give us a clear guidance going forward into the assessment so we can know what's going on there. And the most helpful medical records to submit would be the past 2 to 4 weeks. I know we often highlight the past 12 months, but really the past 2 to 4 weeks are going to give us the most clear picture of how the consumer is functioning at the time of the assessment or shortly before. In the assessment, we as assessors are not allowed to give credit for consumers with physical therapy and skilled nursing specifically if we don't have the current medical records on file to support ongoing care, even including the week leading up prior to the assessment. And this information is really consistent even with what our administrative law judges are looking forward to in fair hearings. They really want to see at the time of the assessment, was the client attending or receiving any of this skilled care? Leading into point 19, this one is really big for assessors. Specifically, we do every single one of the assessors look at significant changes noted by the provider or care coordinator here in this section. We are looking at the past 12 months here. We do want to know what has taken place. Have there been any changes? Did the client experience a stroke? Are they bedridden? Are they resistant to care? Are they nonverbal? And all of this information helps us to be able to better address the consumer during the assessment as well. Initial applications in particular, a lot of times we see this section blank perhaps, or even NA put in by providers. And I'm not going to say that's not helpful, but really if you're able to put anything, even in just your discussion with the consumer in your intake meeting, giving us even just a few sentences of maybe their own report of what has taken place or changes in their life that were leading up to submission of the assessment is super helpful. Again, this can be brief, but it does give assessors a starting point on what they can expect to hear, see in the assessment. Helps us be able to address the consumer better as we get in there for a brand new assessment. And then lastly, in renewal applications, we just ask that we're only providing information on what took place for the consumer in the past year. Sometimes we get information on maybe what happened 5 or 10 years ago. And if you must submit information like that, we just ask that you be brief and really only address what has taken place in the past year. Assessors are really only able to include that information in the assessment, so it's helpful if we see that mirrored in the application as well. And then lastly, like Kimberlina had mentioned earlier, we are asking that when collecting medical documentation from providers in particular, we know that ROIs and release of medical records is taking longer than expected nowadays, but we just ask that you please don't withhold any medical records. If you have them, even if it's minutes before the assessment, or perhaps even a day or two after the assessment, please always go ahead and submit those records. In Harmony, attach the assessor's name, and then we can list medical events in the assessment as factual information. We can document it that way rather than just giving the information in the form of the consumer's report.
Thank you so much, Michaela. I'm going to scroll down to 20. 20 is really an optional box. It's where we would want any additional information about the applicant's health that the assessor should be aware of. So this is where you can put that miscellaneous information that may impact the assessment outcome. It could even have to do with their living conditions. It could have to do with their family dynamics. Anything that you think might be relevant that doesn't really fit anywhere else can go in box 20. So that's what this is reserved for. And we'll go to Eli for 21. I'll scroll down here. 21 is kind of a large section here. Go ahead, Eli.
Good afternoon, everyone. So this section is important for the assessment and the assessment process because we want to know what provider the consumers are saying, and because will be beneficial to us. We're looking at the last assessment, or not assessment, the last appointment date. This is also important section to be filled out. So for the assessment process, I will save time during the assessment if we have an updated list of the providers with the information needed. The other important thing is, like, if you're looking for escort, this section need to be filled out in the CAT to help with the algorithm with the calculation of escort. So that's why the assessor will take the time to get the information. So if they had it accurately on the application, then I will check as they go through the assessment. It will be beneficial to all parties. I don't know if David or anyone else want to add to that section, but.
I was just going to say the way that we normally ask that question is, if they don't know what the exact visit date is, we're mostly going to be looking at, give me a ballpark figure of when it was. Was it before Thanksgiving? Was it after Valentine's Day? Give me an idea of when it was. And then we also know that if the medical visit was recent, it's their primary, and we've seen a decline where that visit is really paramount, we know that we can go get some medical records related to what's happening to them. So their condition, if there's been a change and that medical visit is right in there, then we can easily go get that information. So that's always super helpful to our team.
All right, I will scroll down to 22 and we'll go back to Eli for 22 and 23 here.
Medication is important section in the CAT as well. And it's also, as many of you know, it's time consuming when the consumer has a long list of medication. If all the medication are accurately on the form, that will also save time in the assessment. Instead of writing down each medication that missed or dosage, and it takes about, I'm sure it takes, Michaela probably can tell me how long that will take, but will be beneficial to all parties to have this is updated in the application. And the question number 23 is just, please make sure that you check in the right boxes. If you want an assessment and instead of a comprehensive file review, please let us know. Make sure you check the right box. Of course, the comprehensive file review, as you know, just we're gonna review. Some of them will be approved, some of them will be denied, and reassessment will be requested. But it's good for us to be secure about your request.
Thank you so much, Eli.
Yeah, you bet.
All right, 24 and 25, just make sure those are filled in, and then also with the signatures. I'll jump down to section 5 here. If there is anything, so a list of hospitalizations or ER visits, or even the list of medications, anything that does not fit in any other section of the application that you need to expand on, this is the section to do it. And assessors do check this when we're going into the assessment. Outside of that, we're going to go back to David. He's going to talk a little bit with us about fair hearings and mediations. And I'll go ahead and stop sharing.
So when we're talking about fair hearings and mediations, I think the hardest part that we've identified is really kind of matching what the request is for the consumer. And I know that there's sometimes there's some confusion there. So when we get into a mediation, the first step in the mediation is really finding out what the consumer's disagreement is. That's always the hardest part. And especially when it comes to the waiver, we're trying to boil it down to what is your path to qualifying for level of care. And a lot of times consumers they really have no idea. And sometimes I don't know if the care coordinators have had that chance to really speak to them about it, about what the steps they need to take to get there. And anything that we can do to help bridge that gap so people kind of understand these are the 7-8 ways that you can easily make it onto nursing facility level of care. Is it going to be functional? Is it going to be cognitive? What are we looking at so that we can reach this threshold for the consumer? Same thing with personal care services in a lot of ways. It's okay, what are your disagreements that we might be able to take and approach to some kind of agreement? I know that the personal care services are significantly easier for us to take and resolve ahead of time, but it's really just being prepared in the sense of knowing what the consumers are asking for, getting those areas of disagreement, kind of having an idea of what their needs are that they're requesting and what it is that we're looking for. If we're missing information because the assessment happened weeks ago, we've had a surgery or a stroke, or they've had a critical incident in between, there's additional information there that we can really use. And it's really helpful to get us over that hump. But we still need that. I still think that lack of understanding of what people actually are trying to get when they go to mediation and fair hearing, I think, is the hard part.
Thank you, David. So I'll wrap up here with some other areas that we would also appreciate your help with. Just to piggyback off of what he said, explaining the programs to the consumer so that they understand what they've applied for and what it actually takes to qualify for nursing facility level of care. Sometimes our assessors are having to do that in the assessment, and it would just be really helpful if that was kind of explored more before going into the assessment so they really understood why the assessment was taking place, although we do our part to explain that while we're there as well. Submitting waiver and CFC applications together when possible, that would also be really helpful for us. Communicating to the consumer when the application was submitted and then helping to manage those expectations on how long the process can take. Keeping demographic information in Harmony updated. High priority areas for our unit in particular are the addresses. Where are we sending our assessor to? Phone numbers, who are we contacting? Legal representative information when that has changed, so they have a new power of attorney, etc. That's really helpful to have that updated. And then also the contact for scheduling. Meeting with the consumer prior to the assessment if possible. Sometimes we're told that this is the first time a care coordinator is meeting their recipient. And I understand that there isn't a requirement to meet them beforehand, and things with the PHE probably change the atmosphere for us on that. But if it is at all possible, I think that's really helpful for our unit as well. Also helping to remind consumers of the date and time of the assessment and the requirement that we have for them showing their photo ID, having an updated medication list, having an updated provider list for us, listing out all their hospitalizations and ER visits within the last 12 months and any therapy records leading up to the assessment within 7 days. Attending the assessments when possible, I think is really helpful. And then waiting for the assessor's prompt to provide feedback during the assessment versus providing feedback while the assessor's in the process of conducting the assessment would also be really helpful. Okay, I know we have 5 minutes left here, so I will open it up for questions. If you want to just raise your virtual hand, we can do it that way, and I will try my best to get through the chat as well. So I apologize if there are any questions there.
If we run out of time, that's okay, because we do save the chat and we could send it to Kimberly and her team, and then they could answer those, if we need to issue like an email or something with answers to those questions or something. So if you don't get to your questions, no worries, we will get to it later.
Thank you, Kat.
The ones I know how to answer, I'm kind of trying to answer in the chat. But some of these, it's really for you guys. Thanks.
Okay, I see one from Jacqueline here. I had to hop on a phone call really quickly. Are we supposed to get 2 sets of medical records at the time of the application submission and right before the assessment? So yes and no, I would say it's really case by case. What we're looking for with the application is that list that we have on the checklist. But at the time of the assessment, we understand that there may have been a new condition or things may have changed between the application and the time of the assessment. And for assessment purposes, we're really looking to support our findings with evidence. And that's why we're asking for additional records at the time of the assessment. So while we may not always request records at the time of the assessment, we typically do when we find that we're lacking, especially in regards to a condition or a limitation that the recipient might have, if that makes sense. Great question. Let me see here. Do assessors routinely review the medical information that was submitted ahead of the assessment? Yes, it's part of the prep work that we do before going into an assessment. And checking if I understand correctly regarding therapies, are you saying that the PROM may not or no longer be approved, not currently receiving PT? Kim, I might need a little bit more information on that question. I know that with us, we're looking for recent records speaking to the PT that's occurring right now. So if we're having the assessment today, for example, we would want to see PT records, let's see, just counting back 7 days. So April 30th, I think. Yep. So we would want to see PT records from April 30th to today, if the assessment took place today, so that we can document that accurately in the CAT and give credit to them for however many visits that they're getting on a weekly basis. Okay, let me scroll down here. There are a few assessors that are adamant that all falls in ALH are to be reported as CIRs. Are the assessors trained that all falls must be reported, even the non-injury falls that they are saying needs to be CIRs? Okay, I see David's responding as well. Only falls regarding medical intervention or checkup need to be reported as a CIR. Okay, and then Kara's adding some information there as well. Any idea on the backlog for assessments, like how far behind we are right now? 30 days. Yeah, so I would say we're still processing renewals probably at about 60 to 90 days out. So that is our current backlog time frame right now for renewals, if that helps. Okay, and then when will medication stop printing in the support plan? Okay, I don't have that. Looks like Kat's responding. I'm doing my best, guys, reading
We're
through all the
working on
chat
that.
here.
We don't have a date for when that's going to be fixed.
Okay, let me go down here to the next one. Okay, I think this one has to do with PCA. For the past few years, it seems we will have an assessment. PCA hours will be approved based on the assessment. Then when we submit the waiver 3 to 6 months later, then we will suddenly get a reduction in PCS hours. Shouldn't the PCA be based on the CAT and independent of other services which can fluctuate year to year? This seems like a real change in how assessments lead decisions on PCA time in the past.
There might
That's
be a misunderstanding of terms there. The review unit will issue a reauthorization of existing personal care service hours. If we do a new assessment, we may need to adjust the personal care services hours, especially if there's something in the support plan that might duplicate with PCS, because that will happen as well. If there's, for instance, chore services will replace IADLs, things of that sort. So it would really, I'd really need to see what you were looking at as far as a case by case basis. Sorry, Kimberly.
No, thank you, David. I think we're at time. So for the other comments in chat, we will work on responses back to you. And Nathan, I did read your comment. If you could give me some more information, I'll put my contact information in the chat. I'd really love to follow up on that as well.
And we could
As we-
keep this open. We could keep the room open for another few minutes. So if you have more questions, you could put them in the chat and we'll make sure that they make it to Kimberly and her team. So she could respond.
Thank you, everyone. Really appreciate your time.
Thank you so much for coming. I'm so glad you guys came to finally put the face with a name.
Yeah, thank you for having us.
Yes,
Kat.
thank you.
Good to see you all.
Yeah, thank you so much. Great discussion. Okay,
Please,
so we'll
please reach out to us as much as you can. We love talking to you. So thank you.
sure. So for care coordinators, we'll have the session recorded. I'm going to go ahead and stop recording right now.